Good afternoon. Welcome to the VisualDx Clinical Education Series on syphilis. I'm Leslie Kumler, Marketing Coordinator at VisualDx, and I'm pleased to introduce today's presenter, Dr. Marguerite Urban. She's a professor in the University of Rochester Infectious Disease Division and is the Medical Director of the STD Center of Excellence, part of the New York State Clinical Education Initiative. And without further ado, I'll hand the webinar over to Dr. Urban.
Okay, thanks very much. Thank you for inviting me. So let's start just talking a little bit about the history of syphilis. This is a slide that came out of the CDC STD surveillance report, which is issued annually. And it goes through the history of syphilis in the time that we've had data reported. And you can see back here in the 40s, the blue line is total syphilis, and these two lower dashed line and dark line are essentially recent syphilis present for the prior year. And we had quite a bit of syphilis back in the 40s during the war. And right around the end of World War II is the beginning of the antibiotic era. And there were major campaigns at that time to reduce and eliminate syphilis. And we were fairly successful in that until around here in the late 80s, early 90s. This is actually right when I personally was finishing medical residency training, and I ended up working at the Philadelphia STD clinic on a CDC HIV and syphilis study. And at that time, in the middle of this outbreak that we had, I saw about 25 cases of syphilis a day in that clinic. And that was shocking to me coming out of residency. I thought of syphilis as a disease of, the Middle Ages, really. That outbreak was largely a heterosexual outbreak that was very linked to the use of crack cocaine. And with great public health interventions, we saw a decline of that outbreak that was coincident with the rise of HIV. So a lot of the public health interventions to reduce HIV also helped in that reduction of syphilis. And we went to a period of really record lows of syphilis in the United States, to the point that we hoped to actually eliminate indigenous syphilis. There was a campaign for that. And then you can see on this big graph, we start to see this uptick. So we have a slow rise in syphilis cases. If you zoom in, though, into between 1990 and 2016, you can see that the uptick is actually pretty steep. This dark line here is a rise in cases in men. This is rates, so male rates went quite high. This is female rates down here. And the dashed line is the ratio of men to women. And you can see right around 1999, we have a steep rise in the ratio of male to female cases occurring, kind of levels off, and then another steep rise and a little bit of a decline now. That decline is actually related to a rise in female cases as opposed to a fall in male cases. And when you look a little closer, most of those cases in men have been in the MSM population, the population of men who have sex with other men. Because of the length of time of this webinar, I've taken out some other epi slides, but throughout this recent rise from the early 2000s to present, we've had really a steady increase in cases from that time, as I said, largely in the MSM population. And really, throughout that entire time, about half of the cases, new cases of syphilis occurring in the MSM population, already have HIV infection. So you can see there's really coincident outbreaks there of MSM and syphilis, a lot of co-infection. Syphilis is not distributed through the U.S. Uniformly. This is a map from CDC from the surveillance report in 2016 that is broken down by county, and the sort of darkest blue colors are the highest case rates. So you can see that there are quite high rates along the coast, but really where we are in New York State, you can see really there are cases of syphilis really spread throughout New York, including in some quite rural areas. As someone who tracks this, follows this pretty closely every year, I can tell you that particularly in New York, the concentration of syphilis has spread more widely throughout the state, and the absolute numbers of what the rates are have increased each year. So let's get into talking about the disease itself. Before we start, I just want to talk a little bit about diagnostic methods. And really, with any infectious disease, there's 3 different ways to make the diagnosis. You can recognize the clinical syndrome, and in the case of syphilis, this is often quite tough. There are all sorts of sayings that you might remember from your medical training. To know syphilis is to know medicine. Syphilis is the great imitator. And that really tells you that there's quite a wide spectrum of illness. We'll talk a little bit about the actual physical manifestations in a bit, but chancre and rash are the most commonly identified, but there are quite a few other physical signs. And in addition to sort of the wide spectrum of clinically evident illness, there are also long periods of latency, so making it hard to recognize a clinical syndrome. The other way to diagnose an infectious disease is to actually identify the infectious organism. This is particularly tough. The organism that causes syphilis is Treponema pallidum. It's very hard to work with in a lab. It's not easily cultured. And it's quite hard, actually, to find readily available tests to identify the organism. You can use a dark field microscope. There's PCR available now, and there are some other laboratory tests, but they are not widely utilized. And then the third way is to identify some immune response to the organism, or serology, antibody testing. And really, in the case of syphilis, this is the cornerstone of the diagnosis. But like most things in syphilis, even using serology is quite complicated. There are 2 types of serologic tests. Depending on your age, you might be more familiar with one than the other. When I started out in medicine, we used the non-specific, non-treponemal antibody first as a screening test, and the one that is most widely available in the United States is known as the RPR, the rapid plasma reagent. I've listed a couple of other examples there as well. This is a non-specific antibody by definition, so it's actually a human anticardiolipin antibody that goes up with very inflammatory conditions like syphilis, and it comes down as inflammation decreases. Because it's non-specific by nature, it cannot be used alone to make the diagnosis of syphilis. The way the test is performed, you are able to get a quantitative result, and that is reported as a titer. For example, 1 to 256. It may actually be negative when syphilis first begins because it requires a little bit of time for your immune response to develop. And because the RPR, for example, is nonspecific, if that is positive, it is quite routine and often automatic in most laboratories to go on to a reflex test that is a specific treponemal antibody to confirm that the reason that the nonspecific is positive is actually syphilis. I've listed here all of these abbreviations. These are all different specific T pallidum antibody tests that are available currently. These are a little bit different than the nonspecific. They are largely a qualitative result, so you essentially get a positive or negative result. Some of them have kind of a gray zone, maybe weakly reactive or indeterminate in the middle, but you generally do not get any sort of quantitative measurement that's reported to you. When people have syphilis and develop a specific treponemal antibody, for most people, it used to be said all, but now we know that there's a little bit of variation, but really for most, that antibody persists for life. So a specific treponemal antibody is not really able to distinguish past or present infection, particularly when somebody's had syphilis more than once. It is true also that the specific treponemal antibodies are positive a little bit earlier than the nonspecific. So as someone has first acquired syphilis, the time frame when the antibodies become positive differs slightly, so the specific antibody might be positive about a week earlier. With both of these, in all situations in syphilis, you actually need both types of antibody tests to make an accurate diagnosis. And how the tests perform can actually be a little bit complicated, and it varies by when in the clinical stage you're seeing the patient. So just to go over a little bit of vocabulary and give a bit of an overview before we go into more detail of the stages, I just wanted to go through this diagram of what happens sort of in the natural history of syphilis. You have back here, you have some sort of sexual exposure, and then a period of incubation when a patient has acquired syphilis. That period of incubation can be actually up to 3 months, so it can be 90 days. At that point, the organism has its first clinical finding, and that is what we classify as primary syphilis, when an ulcer, or what is known as a chancre, develops. That then heals spontaneously, and some weeks to months later, the organism disseminates and leads to the secondary stage, where there are many, many clinical findings that we'll go into in more detail. That lasts for weeks to maybe a month or a little bit longer. And then again, without treatment, the organism becomes more quiescent and the stage of latency develops. And that, by definition, are no clinical findings, but the disease persists. So there's no symptoms at that point. And then sometime in the future, a certain proportion of people who are not treated will develop the clinical findings of tertiary syphilis. And we'll just mention those later. And then down here, I just mentioned that from a public health perspective, we're particularly interested in those time frames when a patient with syphilis is potentially contagious, and so the disease can spread throughout the population. And that is, in the United States, we classify that as primary, secondary, and early latent stage, which is a stage out to 12 months. So how you think of these varies a little bit on your perspective. If you're a clinical provider seeing a patient in front of you, you're thinking of syphilis largely by the presence or absence of symptoms. And the symptomatic stages are those numeric terms, primary, secondary, and tertiary. And the asymptomatic stages are, by definition, the time when the disease is latent. If you're approaching this from a public health perspective, you think of the stages more in terms of contagiousness or the infectious period. And then you're thinking of primary, secondary, and early latent syphilis, which by definition in the US is syphilis of less than 1 year's duration. And from a contagious point of view, we always consider syphilis contagious from mother to fetus. The non-infectious stages include late latent, so long-standing latent syphilis, and tertiary syphilis, late complications of syphilis. So let's talk about the first stage, primary syphilis. This is the development, the clinical manifestation that happens, the first manifestation after infection. As I mentioned, that incubation is somewhere between 10 and 90 days. That's a really important number when you're thinking about potential exposures of partners. The average incubation is about 21 days, so 3 weeks after exposure is when most people will develop that first clinical manifestation, but it can be out to 3 months. That first manifestation is known as a chancre. It's a lesion that starts as painless erythema. It subsequently ulcerates and then leaves this chancre or ulcer, which by classic description has a very clean base and a clear exudate. Generally, the ulcer is indurated, so the edges are slightly thickened, and this is actually the most helpful clinical finding when you're trying to distinguish one genital ulcer cause from another. So if you have a lesion and you try to oppose the edges, between your fingers, the syphilitic chancre sort of resists that. Whereas genital herpes, which is by far a more common cause of genital ulcers, it's very easy to move those lesions around. In primary syphilis also, there's often an associated painless unilateral lymphadenopathy. One hallmark that you might remember from medical school or your clinical training is that the classic syphilitic chancre is painless. And since it is often in a location that's difficult to see, such as the genital area, and it doesn't hurt, it may come and then resolve spontaneously without the patient ever knowing that they had it. So I've got several pictures here. This is a very classic, sort of well-demarcated lesion. I think you can appreciate that the edges are a little bit indurated here. It's got a very clear, clean base. But in the real world, you'll find that things are not always so classic. So this is a more irregular shaped lesion and maybe not quite as clean a base. I find this one to look a little bit more herpetic to me. It looks more superficial, not quite as indurated. And here you have a healing lesion that you could maybe dismiss as not ever have been an ulcer. These are CDC slides. This shows you quite a lot of induration here. And this is a much smaller but sort of a well-demarcated lesion. So you can see there's quite a variety of presentations. The lesion is not always genital, and sometimes perianal, which is sometimes much harder to appreciate, again, because often these are painless, and if the patient or you as the examiner are not really doing a very close exam, can be missed. So to make a diagnosis of primary syphilis, by definition, you need to identify some sort of mucocutaneous ulcer. And as I mentioned, you look for a lesion that has a typical clinical appearance, and induration is the most helpful sign we find to distinguish between other causes of genital ulcers. At this point, if you have a lesion and you have access to some sort of test that you could use on a specimen from that lesion, you could make a diagnosis that way. And that could be a dark field microscope, it could be a direct fluorescent antibody test, a PCR, or even a biopsy. These lesions generally last days to a few weeks. And in the first 7 to 10 days that they're present, the antibody testing may be falsely negative because the immune response is not yet developed. And as I mentioned earlier, if you are ordering antibody tests, this is a situation where you wouldn't necessarily rely on the default algorithm from the laboratory, but you would prefer to order both the specific and non-specific tests because you're looking for that earlier positive. The conventional wisdom of the non-specific tests is that the fluorescent treponemal antibody, ABS, is the earliest to be positive among that list of several specific antibody tests. When the RPR turns positive, generally after 7 to 10 days, the titer is usually still on the lower end, somewhere between 1 to 1 and 1 to 8. The absolute value of a titer can never be used to determine the stage, but this is just sort of a rule of thumb to help you in thinking about a case. So your titer is just starting to go up. Secondary syphilis occurs after the resolution of the chancre. That heals spontaneously, even without treatment. And then several weeks later, several weeks to a couple of months, the manifestations of secondary syphilis occur. This happens when the organism disseminates really throughout the body. It can be a very widely disseminated infection with many clinical signs or symptoms. The one we most often think of is rash, and that rash even is a bit complicated because it has a progression. So it starts as a flat macule that then becomes papular, that then becomes somewhat papulosquamous, so starts to scale and may itch, and then it resolves over typically weeks, although I have seen it last even a few months. We are taught in medical school to think about syphilis when you have palmar or plantar lesions. This is not necessarily because everyone with syphilis develops this, but more because so few other conditions cause a palmar or plantar rash. Another term you'll often hear about syphilis rash is nickel and dime lesions, and this refers to sometimes the size of the lesions that you might see. But it's not all rash. Many people also have systemic symptoms, almost like a flu-like illness. So you can have fever, headache, malaise, myalgias, arthralgias, really looking very much like acute HIV infection or other causes of flu-like illness. You can also have generalized lymphadenopathy. There are oral lesions known as mucus patches. There are some warty-like lesions known as condylomata lata. And there's another characteristic kind of finding known as patchy alopecia. And then in addition, this is really a very, very inflammatory condition in the secondary stage. You can pretty much have any itis. Itis means inflammation of, and so you can have hepatitis, nephritis, iritis, uveitis, otitis, really pretty much any itis you can imagine meningitis has been reported with syphilis. So I'm going to show you what most clinicians end up seeing is rash, and again, like the genital ulcers, these also have, depends on when in the manifestations you see it, and there's a wide variety of presentations. So here you can see some more raised papular lesions. It's hard to know when you're not exactly examining the patient. Some almost look a little bit pustular. Here a little bit different, but still quite prominent. Here you can see they're not all the same size, and you might have even sort of large patch that you could imagine mistaking this for pityriasis. These are much tinier and fewer lesions, and even fewer still here where you just have a little bit of scale. This is a patient looks completely different. Big patches, very scattered. Here's an example of that patchy alopecia. This patient I know was worked up for psoriasis. I recently did a literature search of the last 2 years to look at sort of what's new in syphilis for a different presentation. And I was really struck by how many case reports have come out fairly recently with syphilitic rashes being mistaken as psoriasis, and then that presumed psoriasis being treated with immune modulators. So that's really quite a concerning development. So when you're looking at a rash and considering psoriasis, it would be worth considering syphilis in the right setting. Here's an example of sort of classic palmar lesions, sort of nickel-sized here. These are a little bit smaller, and you can see in different stages, they start to scale here. And here, looking really quite different from the other 2 lesions I showed you. I think if anything that I've learned over 25 years of seeing syphilis patients is that it really is the great imitator. You really can't say that there is one characteristic finding. I've been very struck by how wide the manifestations are. And it's sort of a bias to take pictures of rashes that are quite impressive, but it's been striking to me how often you can find quite a subtle rash, really not widely spread on the body. So again, with the right history, it's important to think about syphilis, particularly in this time of rising rates. Here's some rashes on the face, which you don't normally think of with syphilis, but can definitely occur. And particularly around the cartilaginous areas, you can see these sort of whitish plaques and sometimes even cartilage erosion. And here are some oral lesions. These are an example of mucus patches and some more oral lesions. This is a patient that had adenopathy really visible across the room. No rash, no genital ulcer, quite a high RPR, HIV negative. And here's an example of condylomata latum. These, in my experience, have been sort of warty appearing, a little bit moister, and sometimes will ulcerate and have a little bit of bleeding. So the stages of secondary syphilis, you really need to find some physical finding that is in the definition of secondary syphilis. And at this point, specific and nonspecific antibody tests are positive. Some lesion tests may also be positive, particularly those condylomata latum. They have a lot of organism present. The RPR is extremely sensitive in secondary disease and generally quite high, 1 to 16 to much, much higher. We've seen well into the thousands. And then all of those findings may disappear. They're self-limited, and again, the patient may not notice them. And the disease progresses to latency. By definition, in the United States, early latent syphilis is when you have positive serologic tests for syphilis, and no evidence of that was acquired in the prior year. And we do that by seeing if the patient has a history of the signs or symptoms within the prior year, or do they have a negative syphilis test within the prior year and it's now positive, so they've converted, or they're a known contact to an infectious case within the prior year. They meet those definitions, it's early latent. At this point, the RPR is generally trending down, back down toward 1 to 8 or so. And then if you're not in that situation, we call that late latent, no signs or symptoms, and none of those conditions where we can say that it was recently acquired. And this period of late latent syphilis can persist for years. Conventionally, we say it's usually low-level RPRs, 1 to 8, 1 to 4 or less. And some people may even revert to non-reactive many years after acquisition of the disease, even without treatment. Maybe a third of people, somewhere between 15 and 40%, will go on to develop the findings of tertiary syphilis that I'm not going to go into today. But they are guminous syphilis, which is basically granuloma, cardiovascular syphilis, which we think of aneurysms, and late neurosyphilis. One thing I did want to mention, there is a CDC advisory out about an increase in cases of ocular syphilis. Most of these have developed in that itis stage of secondary syphilis with iritis and uveitis. These case reports came out of the West Coast initially in 2015, and there was a recent update in late 2016 with close to 400 cases in 8 jurisdictions in the US. These were primarily in men who have sex with men. About half, just like all cases of syphilis, already had HIV. Some of these cases have gone on to develop blindness, so this is an important thing to consider when you diagnose somebody with syphilis or when someone with risk for syphilis might come in with ocular symptoms. The management of syphilis is maybe the simplest part of it. Because of the high rates of co-infection with HIV, everyone should be tested for HIV, and if they are negative, retested in 3 months. Penicillin is still the drug of choice. And like other contagious, treatable STDs, sexual partners of patients with infectious syphilis need to be evaluated and potentially treated. The treatment for syphilis is fairly simple. It's still penicillin as the drug of choice. And for disease that is recent, meaning primary, secondary, or early latent, present for less than 1 year, it's 1 shot of long-acting benzathine penicillin, 2.4 million units IM, or in the case of allergy, doxycycline, 100 milligrams twice a day for 2 weeks. For long-standing syphilis present greater than 1 year, it would be 3 shots of benzathine penicillin given once a week for 3 weeks, or in the case of allergy, doxycycline for 4 weeks. It is important for contagious syphilis that sexual partners from the last 90 days, remember that incubation, need evaluation to see if they're already infected and treatment even if their tests are negative, because they could still be incubating and develop syphilis, the manifestations, a week or 2 after you see them and then pass it on. So that is essentially post-exposure prophylaxis given if they were exposed within 90 days. And one other important point, penicillin is the only recommended treatment in pregnancy. So in the setting of a serious penicillin allergy, the recommendation is that a pregnant woman be desensitized and treated with penicillin. Follow-up is also a little bit complicated. It is recommended that close follow-up be given, and in the setting of HIV, the follow-up is a little bit more rigorous. For primary and secondary syphilis, the recommendations are to repeat testing at 6 and 12 months, and here are the distribution for HIV. For latent syphilis, you go out 6, 12, and 24, and a little bit more often in co-infection with HIV. What you're looking for is a decline of your RPR titer by 2 dilutions in primary and secondary within 6 to 12 months, and by 2 dilutions 12 to 24 months in latent syphilis. 2 dilutions means falling from 8 to 2. That's a 2 dilution or 4-fold change. A 1 dilution would just be 64 to 32 or a 2-fold change. People use that dilution or a 4-fold interchangeably, and that's sometimes confusing. And finally, I'm just about done here. If someone develops new signs or symptoms or fails to have their symptoms resolved, if they have a 4-fold or 2 dilution rise, or they fail to decline according to the CDC guidelines, we would call that treatment failure. And in treatment failure, we often retreat with a longer regimen, and we consider obtaining CSF looking for possible neurosyphilis as a sequestered site where maybe that would account for the treatment failure. So finally, this is a lot of information just in a half hour. There are some really, really good resources on the CDC's website. The CDC STD treatment guidelines are quite comprehensive and have an extensive section on syphilis. They also have some provider tools that are free. And they also have an app available for iOS and Android phones. So with that, I'm happy to take any questions that you may have, and thank you for your attention.
Just give you a minute to come up with a couple of questions if anyone has any. Okay, well, it looks like you've answered everyone's questions, Dr. Urban. So thank you all so much for attending, and a recording of this webinar will be made available, and we'll send you an email letting you know how to access that. Thank you so much, Dr. Urban, for joining us.
Thanks.